So thank you. I think you have a great opportunity here to listen many different topics from different surgeons, each of our factors, PR. I have no financial interest in this topic, and inconsistent platelet concentration. So plasma-rich growth factor try to resolve these problems, these limitations. This is a novel type of platelet-rich plasma. You may have read or listened about platelet-rich plasma. It is an autologous biological material that we obtain from the patients that we are going to operate immediately before surgery. And we inject into the eye, as I mentioned, for the several conditions. I will explain the story of this, at least my experience with this hemoderivative components. So, plasma-rich growth factors, PRGF, is a novel type of platelet-rich plasma. It's produced in a quicker, more controlled, and more predictable fibrin formation and platelet degranulation. So let me show you how it works. So a patient blood sample is collected in these 9 millimeter tubes containing sodium citrate as anticoagulant. It is centrifuged at 580 J for 8 minutes, obtaining platelet poor plasma in the top, platelet-rich plasma in the middle, and the lymphocyte column at the bottom. So fraction 1, that is the plasma above fraction 2, is removed and discarded. Fraction 2 is the 2 milliliter plasma fraction just above the sedimented red blood cells. And this is what we are going to use to prepare PRGF. The last step is the activation of this platelet-rich plasma with the endoret activator, that is with the activator of the system. And now we have the PRGF prepared for the intraocular injection, and it is injected into an air-filled eye. It can be more easy. It's really easier than any other procedure and very useful for several conditions, as I show you later. So we inject several drops. How many? Many years ago, when we started with this, we decided to use 3 and to check if it was enough, and we saw that it was. So we inject between 3 and 5, depending on the condition, and I will show you later. And this is the appearance of the whitish fibrin clot that covers the macula between 8 and 15 minutes after surgery. So how does PRP work? So PRGF works like I'm going to show you. So the first thing is the anticoagulant present in the blood collection tubes chelates calcium. When we inject the endoret activator, the coagulation cascade is reactivated, obtaining thrombin. And thrombin facilitates on one side the formation and the stabilization of the fibrin clot. And this is how it looks, the fibrin clot, immediately after PRGF activation. And you can see the appearance 5 minutes after, 25, and 40 minutes following the activation. So this fibrin clot increases in density over time and is very stable. On the other hand, thrombin activates the protease activator receptor 1 and 4 on platelet surface, and this induces the release of trophic factors. So here you can see how following activation there is a release of the alpha granules of the platelets, inducing the release of growth factors. So currently there are more than 150 in vitro and preclinical studies on PRGF and more than 50 clinical studies in other medical specialties. It is commonly used in oral surgery, aesthetics, dermatology, and in ophthalmology, plasma-rich growth factors. That is the novel type of autologous platelet-rich plasma. Do you understand very well the differences between them two? So, as I mentioned before, autologous platelet-rich plasma was the original preparation, okay? But as I mentioned in my first slide, it was not very well accepted in our community because of the difficulties in the procedure, as well as the unpredictability of the results. Not all the patients respond the same. Not all the patients develop the same amount of fibrin clot. Not all the patients develop the same amount of growth factors release. So, what is new in the last 8 years is that there is a new topic many years ago. So you can see the preoperative appearance of this optic disc pit. On the right side, you can see the schisses and the macular detachment that is associated with this condition. And 5 years later, you can see the optic disc pit and the complete resolution of the optic disc maculopathy. However, in some cases, like this one, not all the maculopathy disappeared after vitrectomy. There were some remnants of subretinal fluid, some remnants of the schisses. And even years later, these remnants progressed. And there were some other cases, like this one, that resolved nicely, and you can see the appearance 5 years post-op. But 10 years after surgery, there were again images of recurrence. So how can we treat these cases, these complex cases that recur, or how can we prevent the recurrence of this condition? So this is the first case I treated with a platelet-rich plasma. Here you can see the connection between the intravitreous cavity and the schisses in the place where the optic disc pit was located. And there is also a retinal detachment at the posterior pole. So this was the preoperative appearance. The patient was operated with vitrectomy, and 6 months after this surgery, the retina reattached. There is no retinal detachment, but the schisses persist. It remained stable for many years, but 8 months after cataract surgery, the schisses progressed. So a second procedure was performed, doing something that I do not recommend to do, because the story has shown us that ILM peeling in eyes with optic disc pit is very risky. There is a high risk of full thickness macular hole development. But at that time, there was not so many information on that topic, and also I had no other tools to use. So I decided to peel the ILM. I was able to peel it with no macular hole development. However, 6 months after this second procedure, the macular schisses was even larger. So at that time, there was a presentation at ARVO showing that autologous platelet-rich plasma, so what I did, I remind you that this patient was operated twice, so I performed a third procedure, performing only fluid exchange and the injection of platelet-rich plasma under air. Here we are, can you see the optic disc pit? We are with this optic cannula removing all the fluid, and then we inject 3 drops over the macular hole, and this was followed by gas. This is the appearance preoperatively. 1 month post-op. The macular schisses, the foveal schisses resolve with, you can see also the foveal pit. This is 6 months and 15 years after surgery. So we were able to resolve the problem just closing the optic disc pit. We closed the hole at the optic disc pit. Another case, same time, a little bit later, but after, but just very close to the first case. This patient was a woman. She was operated with vitrectomy in other center and was sent to us. And here is the appearance when I saw for the first time the patient. You can see that there is an inner and an outer schisses as well as a macular detachment due to an optic disc pit. After surgery, same technique, fluid exchange, injection of autologous platelet concentration, and you can see how there was a progressive resolution of the condition, and 8 months after surgery, it was completely resolved. So later on, we were able to use now plasma-rich growth factor, this novel type of platelet. You can see that it's a very severe case with an inner and outer schisses with an outer lamella hole. After surgery, only vitreous detachment and PRGF injection, there was a progressive resolution of the condition. 4 months post-op, there is still a defect at the ellipsoid zone, and 5 years later, it remains closed with improvement in vision. And this is the last case I operated. It was 8 months ago. The preoperative appearance with a severe schisis, very severe schisis, and a very thin inner retina. After surgery, a progressive resolution 8 months after surgery. There is still amount of fluid under the retina that it will disappear in the next months. But 8 months was the longer follow-up I had with this patient. So we were so happy with the results that we started treating PRGF in other conditions. And we started with macular holes, with complex macular holes. And I'm going to start to show you some cases of complex idiopathic macular holes. Mario has shown us some cases, but I will focus on PRGF. So, first of all, extra large. Mario saw in his presentation this classification, this new classification. So it's extra large, are larger than 600 microns. This is 60 something macular hole and the closure after surgery. Also, it's very useful for extra large, larger than 800 microns, like this case, which is 857 microns, and the closure after surgery. On the bottom left, you can see the PRGF over the macular hole immediately after surgery, 1 day post-op, but you can see it even better in this case. This hyperreflective material that covers the hole is the PRGF. So this is another case of 800 and something, the pre and the post-operative appearance with the closure of the hole. We have also treated failed idiopathic macular holes, such as this case, the pre and post-operative appearance. In this case, you can see that there is silicone oil because he was a very old man and he didn't want to face position, prone position and after surgery, so that's why we have silicone oil. And then we get into the field where I really have a lot of experience, that is macular holes in high myopia. This is a difficult condition. Primary myopic macular holes. Group 2, 15 eyes with failed myopic macular holes. I don't know if I have a pointer. Do I have any pointer, digital pointer, that I can show on the slide? There's no way here. So, I will show you in here. So, in the full cohort of patients, the macular holes. So in this group, the surgical procedure consists on ILM peeling, fluid exchange. Here are some cases in group 1. This is a patient with a myopic macular hole in an eye with severe posterior staphyloma, and the closure of the hole after surgery with improvement in vision from 2400 to 2200. Another case with severe posterior staphyloma, the pre and post-operative findings. And as you can see, there was a complete restoration of the foveal architecture. A special case is a myopic patient with bilateral myopic macular holes. We have treated also naive myopic macular holes that were associated to choroidal neovascularization, very common in this condition, such as this case, the pre and post-operative findings, or this other case with severe subfoveal lesion, as you can see here, and the closure after surgery. The combination of macular hole, high myopia, and choroidal neovascularization is not easy to treat. Among those primary cases with eyes with macular hole with 809 microns was 93% with significant improvement in vision, and that failed to close with the first surgery. So what we did in these cases, we extended ILM peeling. You can see the preoperative appearance. This patient had been treated previously with surgery and ILM peeling and gas. 4 eyes remained open after surgery in this group. We reoperated 3 eyes. These were the 3 eyes that where we performed a second procedure. We again inject PRGF and inject silicone oil. And this is the closure of the 3 holes after this second procedure. This is one of these cases that persist in group 1, and we operated again. The preoperative appearance after the first surgery with ILM peeling and gas and PRGF. This is the PRGF and the gas. But 2 weeks post-op, the hole was open. So a second procedure, PRGF injection, silicone tamponade. This is the PRGF over the macula and at the center of the hole. 1 week post-op, it was still PRGF, and at 2 weeks the hole was closed. And if there is a case really difficult to treat, it's this one, because it's not only a failed myopic macular host, we can use PRGF as a fluid, as I have just shown you, but we can also use a membrane of PRGF. How is it prepared? Sent to us 635 microns. You can see this is a iatrogenic scar that is nasal to the macular hole. And we decided to operate this eye with a membrane of PRGF. So, small piece of this membrane is introduced into a fluid-filled eye with a forceps through a valve cannula, and it's placed over the macular hole. We don't try to place this piece of membrane beneath the edges of the hole, just to cover the hole. Once this piece of membrane is introduced into the eye, it gets a little bit hard to manipulate it, but it's very easy to cover the hole. And as you will see, it remains stable during fluid exchange. So the next step in this case was to perform fluid exchange. And as I mentioned before, for failed or recurrent myopic macular holes, we prefer to use silicone oil. So after that, we inject silicone oil. And this is the appearance the day after. So you can see that there is the membrane is perfectly at the center of the hole. At 2 weeks, the hole is smaller. This is the appearance 3 weeks post-op, 10 weeks post-op, and 3 months post-op. So what's the difference from my perspective with the fluid and the membrane? I prefer the fluid. It's not only easier to introduce into the eye and to inject into the epithelium, but it also facilitates the regeneration of the retina and the group 2. And using only fluid, not the membrane, this was just to show you, we were able to close the macular holes, eyes with the macular hole retinal detachment. This is a condition that occurs in high myopia, and it's not easy to close the holes, because once we reattach the retina, the tendency is to open the hole, not to close it, because the retina has to So the first step is to stain the ILM. We use William G for that purpose, and then we can peel the ILM with the retina detached, as shown here, peeling from nasal to temporal, or at the perfluorocarbon liquid. So once we peel the ILM, we are going to reattach the retina, and our technique is to perform fluid exchange, aspirating the fluid over the hole. As you can see, when this soft tip cannula contact the fluid over the hole, not in the hole, is when we aspirate. Now, when we touch the fluid is when we aspirate, and we try to maintain the cannula in position, avoiding going deeper to prevent RPE damage. So repeating this maneuver several times, we are able to remove most of the fluid. Then we inject, in these cases with macular hole retinal detachment, 5 drops of PRGF, and this is the whitish appearance of the PRGF over the macular region, and then silicone oil. In these patients, as well as in failed myopic holes, we also prefer to use this. 1 day post-op, the retina is attached, there is PRGF over the retina at the center of the hole and in the retina. At 1 week, the closure started at the inner retina, as always. At 2 weeks, the hole is closed, and there are remnants of PRGF over the retina and beneath the retina. At 4 weeks, there are still remnants of PRGF beneath the retina, as well as at 6 weeks. 8 weeks after surgery, the retina remains attached, and the macular hole is closed. And the case I'm going to show you is really a special case. It's also macular hole retinal detachment. 1 day post-op. PRGF visible over the retina at the center of the hole and beneath the retina. The difference with the previous case is that the retina, as you can see here, remained detached. 1 week post-op, PRGF clot is visible at the center of the hole, and the retina remained detached. 2 weeks post-op, there is still a clot at the center, well, easily visible, and the retina remained detached. 3 weeks post-op, PIGF was visible only as this thin hyperreflective line at the center of the hole, as well as 4 weeks post-op. At 5 weeks, the hole was completely closed and the retina remained detached. During the follow-up, there was a progressive resolution of the subretinal fluid, which completely resolved 12 months after surgery. So, this is a very special case because it shows the closure of a macular hole in a detached retina, which is within common. And also because the macular hole remained closed thanks to this PIGF during the resolution of the detachment, which lasts many months. So the last group of patients we are treating with plasma-rich growth factors. Here are some examples. This is one of them. The preoperative appearance is a patient with a lamellar hole with a lamellar with an epiretinal proliferation at the center. The surgical procedure, post-op under gas. You can see this hyperreflective material, which is the remnants of the PIGF, and the hole was closed 3 weeks post-op. Visual acuity improved from 2070 to 2050, and that's appearance 4 months post-op. This is a lamellar hole also in a high myopic patient. You can see the typical appearance of the lamellar hole. After surgery, visual acuity 2050 after surgery, 2 weeks post-op. There is no gas at the center of the fovea. The lamellar hole was closed, and visual acuity improved to 2030. Another case, in this case, there is a triangular elevation of the outer retina too, with this partial retinal thickness defect, epiretinal proliferation. After surgery, 2 weeks post-op, the lamellar hole was closed, and visual acuity 2050. And this is the last case I'm going to show you. It was a larger lamellar macular hole with a typical OCT appearance with an epiretinal proliferation, 2050 visual acuity, 2 months post-op. We think that the mechanisms that are involved in the resolution of macular holes and optic disc maculopathy with PIGF are two. One is mechanical because the activated PIGF forms a firing club. PIGF, plasma-rich in growth factors, this novel type of autologous platelet-rich plasma, is a high concentration of growth factors. The fact that the surgeon can decide when to